Hello and welcome. Bonjour. Thank you to Wounds Canada for promoting this very important day, Stop Pressure Injury Day. Mölnlycke is proud to sponsor this session titled Pressure Injury Prevention, Synergy in Practice. My name is Nathalie Gingras and I will be the moderator of this session. I would like to introduce our two speakers today, Debra Johnston and Leslie Heath. Debra Johnston is a clinical nurse specialist certified in wound, ostomy, and continence, working at University Health Network, Toronto General Hospital. The focus of her practice is to improve the quality of life for patients and their families by developing and promoting quality care through best practice guideline development and education for patients living with chronic wounds, ostomies, and fistula. Debra has participated in the development of best practice guidelines pertaining to pressure injuries and ostomy care. Leslie Heath is a certified nurse specialized in wound, ostomy, and continence, whose practice focuses on providing specialized holistic assessment, prevention, treatment, and management strategies for patients living with acute and chronic wounds, ostomies, and fistulas. As a clinical nurse specialist, she provides consultation and treatment recommendations while advocating on behalf of patients across the continuum of care. Her role also entails providing leadership, mentoring, and provision of education to patients and staff, as well as program development, quality care monitoring, and participation in research. To view their complete bios, I invite you to visit the auditorium. Leslie, Debra, over to you.
Thank you so much, Nathalie. So on behalf of Leslie and myself, welcome to our talk today on pressure injury prevention, synergy in practice, we've called it. So on behalf of Leslie and I, thank you for joining us today. Our disclosure, so this session has been sponsored today by Mölnlycke, but Leslie and I do not have any other disclosures to declare. So greetings from University Health Network. This is where Leslie and I work. We are a complex network of hospitals. We have 3 acute care sites, 2 rehab, one of which is spinal, and also a complex continuing care site. Both Leslie and I have had the opportunity of working in acute care and also in the community. And so with this experience, I think we really understand and appreciate the challenges of patients transitioning from one healthcare sector to another and the need for collaboration for patient safety among all healthcare areas. Today, our objectives are really revolving around communication, the systems and the processes in which we work. So as we go through objectives today, just keep in mind that we're going to have a slightly different lean on some of these objectives. So we're going to talk about the impact of pressure injuries and the current research that's there. We're going to talk about risk factors, but again, remember, we're going to talk about it a little bit differently in terms of patients and the systems in which we work. We're going to explore the components of healthcare bundles. These are embedded in a lot of our work areas now. We're going to discuss risk assessments, skin assessments, medical device-related pressure injuries, the use of prophylactic dressings, and then communication, education, and documentation. We're also going to discuss what you can do in your practice to prevent pressure injuries from occurring. And then when they do occur, what do we do? Looking at root cause analysis and also looking at the legal implications when pressure injuries occur. So this slide here is a little bit busy. You've probably already seen some of these stats today. They are really looking at the worldwide prevalence and incidence of pressure injuries and also what we have more locally here within Canada. Speakers this morning may have already covered this, and there is a lot of robust data, but it really lacks specificity. And so Leslie and I also echo that same message. We wanted to share some of the information that's available worldwide and also that which is nationally. But you can see how much the prevalence and the incidence vary. And so when we look at the data and when we're looking at how things are being published, we have to understand that the stats are going to vary depending on a few things. So in your own practice, when you're looking at the prevalence and incidence of pressure injuries, take a look at the studies and just see their sample size, the study populations. Some facilities mandatorily report their data and other ones it's more of a voluntary reporting system, while others just choose not to participate. There's a lack of uniformity in defining and including stages, as some centers will maybe look at stage 1, while other centers don't. Also look at the study power and the sample. Was it convenience? Was it randomized? What this slide does show, though, is that we have a real problem. No matter where you work, whether it's acute care, it's long-term care, it's the community, we all have pressure injuries that impact our patients and our practice. This slide looks at the snapshot of pressure injury impact on the healthcare system. Other sessions today may have covered patient-specific impact, but Leslie and I really want to focus a little bit more on the system impact. What you'll see is a net cost of pressure injuries in the first 2 bullets. But I wanted to bring your eye down to the second bullet for the United States hospital-acquired pressure injury costs. 10 years ago, there was data that stated that the hospital-acquired pressure injuries were about $10 billion annually. There was a new study that was done by Padula and DiLamente that suggests that hospital-acquired pressure injuries in the United States could cost upwards of $26 billion annually. In their work, they looked at hospital-acquired pressure injuries, thinking that through the data, each pressure injury would cost about $10,708 per patient on average, exceeding a total of $26.8 billion based on the 2.5 million cases that were presented annually. This analysis also highlights that stage 3 and 4 pressure injuries accounted for 58% of what they gathered in their data. And stage 3 and stage 4 were relatively low occurrence. Most of the pressure injuries they found were stage 1 and stage 2. So what this tells us as healthcare providers is that early identification and prevention of progression is definitely important. I was shocked to read that pressure injuries have been reported to be the 3rd most expensive disorder to treat after cancer and cardiovascular disease. I think another system impact that maybe we don't talk about a lot, but we often see, is that for patients who are not able to return to work. Perhaps they need to apply for provincial employment services, sometimes long-term disability. They may be forced into early retirement due to their pressure injuries. Although not common, I think we've all encountered patient situations, and this data would be interesting to collect. So this slide, I think that all of us can probably recite in our sleep. As part of our risk assessments, we commonly think about the intrinsic and the extrinsic risk factors that are inherent to the patient. And I think as our knowledge of the pathophysiology of how pressure injuries occur continues to evolve, I think this list might evolve as well as different things are realized. For now, though, research in our evidence-based practice is guiding us to identify any modifiable risk factors and put interventions into place which could minimize, not always eliminating though, the risk of pressure injuries developing. But there's another area that we don't address in our assessment tools. It's a huge area that we don't readily discuss, and it can be one that I think can compromise the patient the most. And it's us. It's the healthcare team, it's the healthcare system in which we work, and it's complicated. These photos demonstrate the complexities at the point of care. These complexities are not solely the reality of nurses. It's every profession at the point of care and the demands that exist. When we speak of systems, we all work within a series of complex systems with different needs, different care models, different patient populations, different cultures, and different funding. So for example, you could work in a particular unit of a long-term care facility, and that unit is its own system, if you will. And that unit that you work on is part of a building, and that building could be its own system. And perhaps that building is within the part of a larger chain, and so it have a different government body. Likewise, if you're working in acute care, the unit that you work on could be considered its own system. And then that unit is within the hospital organization. And perhaps that's part of a larger hospital network. And so my question to all of you is, should pressure injuries solely be a nursing sensitive indicator? Perhaps for those preventable pressure injuries, I think it's more of a system sensitive indicator. And this is why I said it was complicated. No matter where you work, you can relate to this slide. Our Caring Safely team at University Health Network has given us permission to share this fishbone, which highlights the complexities of the pressure injury prevention systems in which we work. As you can see, we're all challenged by the same issues. There's lack of resources, inconsistent data, we have fragmented documentation, pressure injury reporting, and I think there's also the stressors of day-to-day care. It's the more complex patients that we're dealing with, the competing work demands within our environment, the constant workflow interruptions, the lack of resources and equipment. And I think in terms of obstacles for implementing those plans of care, sometimes it's a lack of time. There's poor communication, and we'll talk a little bit more about that. A lack of knowledge sometimes, or difficulty with that knowledge translation into practice, which is one of our themes today. So when you think about your system, your unit, your hospital, your network of hospitals, or the chain of nursing homes in which you work, we all have complicating factors which impact the patient care required. So there's healthcare team opportunities. Our patient flow and transition from one healthcare sector to another is happening now at such a rapid pace. There's ERAS in the hospitals, enhanced recovery after surgery. So patients are in and out much more quickly. There's a heightened emphasis now on decreasing time spent in emergency, decreasing length of stay, and patients are moving on to rehab or long-term care with very little advance notice for the acute care centers. I think Leslie and I can attest that sometimes we're told that patients have a bed at long-term care and the ambulance is coming the next day. So you've got only a certain amount of time to bundle that information and communicate that information to the receiving facility. And I can't foresee our system slowing down. We need to be creative and change the way that we work. We need to examine the process of how we practice and operate. But more importantly, for the point of care staff, we need to focus on communication to promote their safer patient care. And I love this quote that you'll see to the right. The single biggest problem in communication is the illusion that has taken place. And isn't that true? We all assume that everyone within the circle of care knows, but this is not true. So many professionals within the center of care, we all need factual and concrete information and documentation to keep everyone aware of the patient goals and the next steps. So thinking about in terms of just documentation, whether it's paper, electronic, or hybrid, is it accurate? Is it fulsome? When we think about transferring patients, whether it's within the unit or to a different facility, within that transfer of accountability, are we always providing the most relevant information? What's the risk assessment factors? What's the care plan? What's the patient-centered concerns? And then there's always the consulting teams to consider, whether those consulting teams are in-house within a hospital, or if consulting teams maybe that are external, that are providing care for patients in a different care center. Have they written their ideas and their suggestions very clearly? Have they relayed their plans of care and the goals and outlined next steps? And sometimes for consulting teams, they can take days to sometimes converse and to resolve some of these communication issues. So our challenge for all of us is how do we successfully implement and sustain change? With a global and national focus on pressure injury prevention. Luckily, we're collectively talking about this a lot more. Sometimes though, it's about timing. Other influencers have been Accreditation Canada, the Canadian Patient Safety Institute for Never Events, and sometimes it can be patient situations, which can be an opportunity and a catalyst for change within our organizations. After today, you will have a plethora of pressure injury prevention information from this symposium, and everyone will be ignited to go back into their institutions to make change. But how are we going to do that? Our solutions must be multifaceted, and they'll evolve, and they'll need long-term commitment. Program interventions may vary depending on where you work, the population that you serve, and perhaps the patient needs that may arise. I don't think that we'll ever reach a spot where we're done. With this initiative, it'll always continue to evolve with new research that's discovered and new strategies that need to be implemented. So we should begin our focus on creating a culture of change that looks at trends instead of finite measures. Over time, sustainment becomes the new norm. So let's get started. We now want to turn your attention to interventions. And we'll be reviewing interventions for patients, but also interventions for the systems in which we work. The communication and the collaborative processes that need to occur for safe patient care. So first, we need to begin with the grassroots. Many of you may have already implemented pressure injury prevention programs at your facility. For those of you who have not, this is where we need to start. It's with the front line. The front line are your biggest investments. They're your most important partner. They'll help you identify issues within your system and where your gaps are. Ask the people at point of care what they think the solution is, knowing that what works well in one area may not work well in another. So we need to be flexible. Pressure injuries, remember, are not just a nursing issue. All healthcare team members, including managers, healthcare, allied health professionals, transitional care coordinators, are also liaisons for patient transfers and discharge, and they also support the flow of critical information. So healthcare providers' need for information and resources to support patient care will be discussed throughout this symposium and throughout our lecture as well. We encourage you to go back to your organizations and ask, what are your issues? What are your barriers for frontline staff? What are your resources that are needed? And what are your opportunities? This is a constant area of focus as staff change. And with education comes common language, empowering staff to provide the best care. We need open communication between team members and permission to call out something that is not safe. Now, this was adopted by the Lean initiatives through Toyota and also the airline industry. We all need to vocalize our concerns, and Leslie will talk more about opportunities a little bit later. So we need to invest in the point of care. Organizations cannot do more with less. Patient care areas have been leaned so much that patient care and safety at times is jeopardized. Organizations can only do more with more. We need an investment at point of care. The communication we're speaking of is with everyone. It's with our porters, our healthcare aides, or PSWs, allied health professionals, nurses, managers, and leaders. Staff providing the care see issues and gaps and opportunities for improvements. With the onboarding of new staff as our population changes, with bed space patients that come to their units, and also during patient transfers. Creating opportunities for staff to communicate their understanding concerns of patient care in a feedback situation such as huddles is one way to promote staff elevating their concerns and their leadership then to make changes. Organizations need to make available financial and human resources, including relevant consults and team members, as well as time and support for the frontline nursing staff. Staff need access to appropriate nursing equipment, supplies, and therapeutic devices to ensure that pressure injury programs are successful. As well, policies and procedures and pressure injury prevention management strategies need to be developed, implemented, and evaluated regularly. So practice pearls. This is another great quote to share with you. How staff perform their work is linked to their understanding of their work. While it's an older quote, it still stands true for all levels, whether you're at the bedside, you're an educator, you're a clinical practice lead, or your administration. Communication and celebration is vital. No matter what position you're in, we all want to do a good job when we go to work. And we need to celebrate those triumphs in our workplace. This could be done by sharing quality reports with staff. I think that would be a testimony to their care and reinforce as well their care and their efforts matter, and it promotes a positive culture change. At a higher level, there needs to be support for educators, managers, and even leaders to help them develop the leadership skills they need to promote a more of an interprofessional collaboration and communication of the vision and goals for change. Prevention is key. Now turning your attention to prevention and management strategies. No discussion on pressure injury would be complete without the inclusion of prevention strategies. Many prevention programs, such as the best practice guidelines from the RNAO and Wounds Canada, the one you see here is from the NPIAP, and all the categories are pertinent based on risk assessment tools such as Braden or Norton, and give generalized principles to base our nursing interventions. I love bundles. Bundles are now a part of everyday nursing practice. There's bundles for CODI, there's bundles for central line infections, there's bundles for VAP, and there's also bundles for pressure injury prevention. The bundles actually refers to implementation of a set of 3 or 6 mandatory interventions that are targeted towards a specific procedure or treatment. More and more, you'll see that bundled approaches are surfacing. Even think about a surgical checklist and a standardized way to approach the most invasive procedure I can think of. Surgical checklists and bundles are also emerging. Personally, I welcome the idea of bundles. I think they standardize the language that we use. They standardize the care that we provide to promote best practice. And in essence, it's a snapshot of an evidence-based guideline. In addition to bundles, nurses will also add other interventions to create individualized patient care plans. The tools that you see here are just 5 that I was able to quickly find from the literature. When you think about skin and risk assessment, I think Norton, Braden, Skypist are your risk assessments that come to mind. And we also have skin assessment tools. They're fabulous because they give us a framework or a standardized way to assess our patients. Skin assessments are a visual barometer of how we're doing with our interventions. If we're not managing moisture, you're going to see MASD or maybe intertrigo, maybe maceration around a wound edge. Skin assessments provide valuable feedback on skin health and guide our repositioning for pressure and then also moisture management strategies for both patients and the medical devices that they have. Our risk assessment tools identify the areas that make our patients more susceptible for pressure injury development. And as our condition increases or improves or deteriorates, we change our interventions to meet their needs based on the subscore categories. Use of a risk assessment tool with sensitivity in your patient population is important. As we develop a deeper understanding for pressure injury development and contributing factors, we may need to change the way that we think about using risk assessment tools to really identify certain patient populations. Another area of focus is medical device related pressure injuries. There's a growing number of studies with their prevalence. So this is one I've recently found. It was a systematic review by Brophy et al. In 2021 that looked at 14 studies with over 2,000 patients. And they found a mean incidence of medical device related pressure injuries, 28.1%. While valuable, this number does not represent the true number of incidents of medical device pressure injuries, as not all studies captured the data in the same way. As well, they didn't all include medical mucosal related injuries. So while this is something that we don't stage per se, we do know that mucosal injuries are definitely related to pressure. The single largest percentage of medical devices were the immobilizing devices, but collectively a larger percentage of medical devices she found were those that were attached to the head. So they're the face masks, the endotracheal devices, the nasal cannulas, the nasogastric tubes, and they dominate the medical devices that cause the pressure injuries in her systematic review. Other devices included ID bands, IV and arterial cannulas, vital sign probe, heel relieving devices, and linen savers. The risk factors for these continue to be critically unwell patients, those with reduced mobility, sensory and perfusion functioning, malnutrition, comorbid conditions, microclimate, and the patient's skin relying on medical devices in order to sustain life were also causative factors. Did you know that medical devices have been identified as a primary cause of pressure injury development in children and neonates? That was something that I learned. I don't deal with that patient population. I found that really, really interesting. So due to the high prevalence of medical device related pressure injuries, we need to focus on this area. And here is another beautiful example of a bundle for this area of practice. We need to identify the medical devices that are creating the injury and create interventions to eliminate the risk. Interdisciplinary collaboration and communication with occupational therapy, respiratory therapy, physiotherapy is very important. And essential for the pressure injury prevention. Medical devices are predominantly composed of synthetic products, such as plastic, which generates heat, moisture, and humidity to an area of localized surface area that creates a microclimate for skin breakdown under that area. In concert, often these areas are edematous, and the medical devices need to be fixated for them to be stabilized. And that can also cause pressure injury development. In Brophy's discussion of the systematic review that she did, she raised a very valid question in that, do we need to develop maybe a risk assessment tool for medical devices? Here's a research idea for somebody. When you think of it, the extrinsic factors are very unique and not captured by other risk assessment tools at this area. Incontinence, we wanted to highlight the importance of incontinence. The study was done on acute care with some alarming results. In such a study, in long-term care, there'd be even higher incidences of pressure injuries. Patients with immobility and incontinence were 3.5 times more likely to develop a hospital-acquired pressure injury. Incontinence and skin barriers are part of all bundles, but it can be an overlooked area. Yes, we have perineal cleansers and skin barriers, but as clinicians, we need to really look at their efficacy, at the products that we use. If your contracted incontinence products are not meeting your patient's needs, we need to raise this within your buying group. Sometimes the products in our formularies may not be awarded based on clinical outcomes. It may be based on cost. And this is a very easy way for addressing an issue that can create pressure injury development. There's ways to elevate this, just communicate it with your managers. We spoke about the need for data to drive funding for practice changes, knowing that IAD places patients at a much higher risk for pressure injury development. Perhaps we should be measuring the prevalence and incidence of IAD as well. And next, we're going to look at prophylactic dressings. This is an area that's gaining more and more attention and implementation. Research has been done in a variety of settings, such as ICU and eMERGE, and I also believe there's studies underway in the OR population. Most impressive was a study by Terib. He did a meta-analysis of 25 studies, which supports the use of a 5-layer silicone dressing to the sacrum and coccyx as prevention against friction and shear. For pressure injury development, product design matters. With technology, the shape of the 5-layer design is very important. In this particular dressing, it allows coverage of the sacrum and also separation of the gluteal folds, reduces friction and shear between the skin as well as during patient repositioning. It also reabsorbs moisture on intact skin and resists skin damage from minor incontinence. It's easy removal and allows a non-traumatizing method to the skin, which allows a routine skin assessment and reapplication without causing further skin injury. This is especially important for fluid overload patients or patients with fragile skin. And so a clinical pearl is that 5 layers really matters and that you get one that has one truth. Over the past decade, we've seen an increasing focus on the use of multi-layered silicone dressings as prophylaxis for hospital-acquired pressure injuries, but they're not all born equal, and they may look similar, but the clinical outcomes will eventually depend on the engineering designs and details. The medical device industry does not apply a strict and mandatory policy of measurable regulations in this regard. This places the responsibility on clinicians to decipher and interpret the marketing material they read, as well as examine the clinical evidence and the validity of the products that they use. And here is an example of another bundle. This is an example of a hospital who included a foam dressing as part of their bundle. Leslie will have more ideas for you within her presentation now.
Thank you, Deborah. I'd like to now continue on with this presentation and talk a little bit more about some of the other aspects that need to be included when looking at pressure injury prevention and what we can do as a system-wide organization. So education is one that's very, very important. Education to all levels of staff that interact with the patient, and it must be multi-pronged and multimodal. Various teachable moments occur that when all healthcare providers, including managers, educators, and experts, can take advantage of these moments, such as bedside shift report, safety huddles, e-learning opportunities, in-person learning, and conferences. Looking at the QI initiatives and providing the staff with the feedback on how did our organization do, how did our unit do, how did we as a group of healthcare professionals do. Changes in the material resources that are provided to the patients also need to be reviewed and planned and executed carefully in a methodical way that makes sense and engages the frontline user. At UHN, we have a patient advisory committee that engages patient partners to have a say in that all important hospital planning and decision-making activities. So when you're providing education to your patient and families, make sure you're including skin and wound care and the reasons for frequent repositioning, when to seek medical attention. If your heels and bum are sore, please to speak up. Looking at the written handouts, making sure that they're at an appropriate learning level. And it's important to have the opportunity for both the patients and the families to engage, because sometimes family members have a better sense of when their loved ones are actually uncomfortable or are too afraid to speak up, in that it may impact their care. It is important to regularly reevaluate the effectiveness of these education programs for both staff and patients so that the most up-to-date evidence-based materials is available. Studies have shown that 40 to 80% of medical information that patients and staff are both told during visits is often forgotten, and that nearly half of the information that retained is sometimes incorrect. So really important for all of us to look at multimodal didactics when we're teaching from both patients and staff. So wherever possible, we recommend that we include a nurse specialized in wound ostomy and incontinence in your team. There's been several articles that are written to prove that having a mentoring, leadership, education, and specialty wound and ostomy and incontinence certified nurse available to guide both prevention, practice, education, and also provide advocacy and development of best practices within your organizations. It's important to be a multi-pronged approach, but also to have active partners in all areas of disciplines within the organization to provide both leadership and implementation, education, and evaluation of the outcomes. We can also help to participate in data collection and analysis. As part of the interdisciplinary allied health team, we can also provide equipment and supplies expertise for both proper utilization and for group purchasing contracts. So including an NSWOC, nurse specialized in wound ostomy and incontinence, is your team, is something that we highly recommend. Communication is another valuable part of teamwork when looking at providing patient care, and we know this from all the aspects of patient care. Unfortunately, there are many possible gaps, as we all know, within the healthcare system. Making sure that we provide effective communication can help to reduce errors, improve patient and healthcare provider satisfaction, and also hopefully ultimately prevent readmissions and even deaths. Unfortunately, as you can see on this slide, there's several areas where communication gaps can occur, both between the patient and the caregiver, between the patients and the care providing team. And so some of the areas that we recommend that you make sure you improve and make sure you focus on communication is between all of these individuals, both during rounds, huddles, when teams are doing their rounds to actually examine the patients, making sure that your cardexes, if your organization uses cardexes, are up to date, making sure that all aspects of the team members are aware of what's happening and how the patient is engaged in their care. Looking at your electronic medical records, we in our organization have bedside shift report, which we find is very, very useful and important. And when you're transferring patients, the transfer of accountability is also very important when you're transferring to other organizations. Sometimes we'll provide emails to other healthcare providers, and making sure that you stay up to date on all the changes that are happening in your organization. So for example, in our organization, we have representation on our patient handling committee, which looks at some of the equipment like the beds and the mattresses that are purchased, for example. So that gives us a say on what's happening. But again, communication is key amongst all care providers. So what we want to do really, and we wish we had this fancy music to introduce this next slide, but really you want to ignite your staff. You want to empower your front line to really help with the prevention practices and embracing the bundles. Within the systems that you work in, we want to make sure you celebrate and share your successes and not just analyze any possible gaps and failures. To inspire passion in others, you must first be passionate yourself. People will always follow a passionate leader. It's also important to know your staff and know how to motivate them and what motivates them. So how can you get them engaged? How can you get them aware and active in the various interventions and education possibilities that you're providing for them on the various units, and also as an organization as a whole. The best leaders regularly provide their teams with opportunities to improve their skills and provide input into all aspects of education and the working environment that they work in, where they can see opportunities for improvement. So again, our organization is very good, and the managers give the staff opportunities to have both a suggestion box or a suggestion board. They often regularly have meetings where the staff will have the opportunity to provide improvement both in workflow and in areas that they see are gaps, both physical gaps, say for example in equipment, but also in the patient handouts, the books that we provide to patients. So very important to have your employees engaged, and so that they have an emotional connection, and they will be much more willing to help out and to provide the support for the organizational values. That's the kind of energy that you want to harness. So I just wanted to go over some of the different organizations that we found that were very successful in some of the bundled approach when you're looking at pressure injury prevention. And as Debra talked about, the bundled approach is often the best approach, having a multi-pronged approach. And so some of these organizations were what we found in the literature that highlighted some of the successes in their bundle creations. Now, unfortunately, when we did our lit search to outline this presentation, there hasn't been anything new in the last few years, but obviously people have been quite occupied with the pandemic. So this is an example of a study that was done by Del Moore in 2011 at the New York Langone Medical Center. And it shows the bundle that they were providing, which is a multifaceted approach again. And what they found in this study is that documentation was actually felt to be the most tangible means to measure whether the nurses successfully translated what they learned in the education sessions and applied that to the interventions and the everyday care of their patients. Making sure that they had somebody that was available from QI that did regular data audits to make sure that the nurses were documenting both fulsomely and appropriately. And looking at these data audits provided transparency and provided for ongoing feedback. It also promoted accountability, and it helped to embed the evidence-based practices. Now, it's important not to make the nurses feel, or the staff, because of course, as Debra outlined, it's not just the nurses, it's important not to make them feel that they are being criticized or examined or under a microscope, but engaged and embraced as part of the team, as a whole team of preventing pressure injuries. Often institutions have the dissemination of monthly computer-generated reports that they can be provided both from the management level and the senior leadership level. And this can help to guide and educate staff on, where the gaps are at a month-by-month basis. Have they had a particularly challenging month where there was a large amount of patient acuity? Were they decreased in staff, and so they had some gaps in staff? Was there a new computer system, for example, being implemented? What were the challenges? What were the barriers? And where can we overcome this? It's been shown by this study that increasing the frequency in which the nurses were implemented and documented evidence-based pressure injury prevention practice interventions, it actually improved to 98% with the continual feedback. And that therefore decreased the incidence of the hospital-acquired pressure injuries that were deemed as avoidable. And so that was a really good success. So we encourage all members to listen to the feedback. So in this particular study that was done by Martin, they found that both the physical and the human resources and communication processes were all perceived to enhance prevention and management of pressure injuries. So as they said, it's definitely a combination of everything, and there's a disconnect between what's needed and what's available. Now, that doesn't mean that we have to have the top line of everything the best of the best at all times. It's contextualizing it to your particular unit. It's making use of the resources that you have, and it's educating all levels of staff again. So in this particular article, equipment was looked at. So things such as low air loss mattresses, sliders, heel lift boots, and incontinent products were all key elements as far as the equipment goes that were contributed to this success. As far as staff goes, healthcare aides noted that they needed to be included. Often the healthcare aides are the ones that are doing the incontinence care and the bathing of the patient. And so unless they are felt to be inclusive and have the comfort level to communicate to the nursing staff and to the other team members, you know, they may not highlight that, oh, you know what, I've been noticing that that patient has a very red bum today and it wasn't there yesterday. And so including them in patient huddles and encouraging them to communicate with the staff and working as a larger team. Staff engagement was very, very crucial. As we've talked about, and we've encouraged the leadership support, being supportive and listening to the staff to have a say. So in our organization, again, and as in many, huddles is a beautiful time, whether it be safety huddles or patients, skin huddles or wound huddles, as some organizations called it. But any time where the staff has that opportunity to get together and report up any questions or concerns about safety, not just for pressure injuries, but for all aspects of the patient care. So some of the takeaway pearls that we learned when we were examining some of these bundles and the successes that we had was that it's important to have a common knowledge platform. Excuse me. And so having that common knowledge platform, whether it be the language, the education, but all of that is important so that everybody has the same commonality and can speak the same language, and that no one person has all the knowledge. All the training sessions that are provided should consist of both theoretical and practical approaches so that you get both the hands-on and the theory, so that patients, both patients and staff, can understand why it's important for these to have the opportunity to have this education done. Looking at external supports can also help to facilitate. So having the external experts, so as I said earlier, say for example an NSWOC, a nurse specialized in wound, ostomy, and continence, so that when questions do arise, when you're looking at your huddles or transfer of accountability, or even at bedside quality improvement measurements, both the nurses and the experts can discuss the individual patient's situation and brainstorm together to come up with, well, what other? It's also important to include your other allied health professionals, so your occupational therapists, your physiotherapists, and not just the specific patients, not just the specific staff caring for the patients in that particular moment, but at all moments of their care during their journey. When you're looking at bedside discussions, making sure that the patient is included. So if the patient says, hey, you know, I want to get out of bed more often, or I don't want to get out of bed more often, which is what we hear more often, it's important that the staff can provide the reasoning for the patients, why it's important, what will happen if they don't, and then how we can work together to make it better for the patient. Team communication we've talked about, so huddles, having that opportunity for staff engagement and staff feedback is very important. And looking at timely resolutions. So this is very important as far as the staff feeling like they're heard, that, you know, I reported that up, but nothing's happened. It's been days or months or weeks. And so making sure that the leadership and the manager of the particular unit gets back to them to say, hey, yes, you know, we've heard what you've said. Unfortunately or fortunately, this is what's going to happen next. And so making sure that that loop is closed and that that engagement and successes have been talked about and celebrated. When pressure injuries do occur, so unfortunately, and I know these are gross pictures, but it is a pressure injury prevention presentation, and hopefully nothing, you know, these aren't seen very often, but unfortunately, sometimes really nasty pressure injuries do occur. So for most organizations and institutions, hospital-acquired pressure injuries, especially severe ones such as these, are required to be reported using an incident report. And so when you're looking at the incident reporting systems, it's important to make sure that the documentation of when the pressure injury was first assessed and found, the type of wound, so what stage of the pressure injury it is, where it is, how big it is, and also looking at the tolerance, so what kind of interventions were put into place, what the tolerance level of the patient was, were they able to engage and respond to pressure offloading or pressure redistribution or the turning frequency that's being recommended by the nursing staff, looking at the types of products that are being used, looking at the patient's pain levels, which is very important. If the patient's having a lot of pain, of course, they're not going to be willing to be engaged and willing to move because it hurts too much. So making sure that we're looking at all those factors, looking at the types of dressings that are used, and also looking for signs and symptoms of infection. Unfortunately, these types of severe pressure injuries can get infected really quite quickly. So one of the ways that you can examine some of the causations or causing or things that are contributing to these pressure injuries development is a root cause analysis. So many institutions perform a debrief of all severe incidents that have been reported in order to analyze the circumstances and what's been happening and where and how the pressure injury did develop. So this slide just shows an example of the National Pressure Injury Advisory Panel, the NPIAP, the root cause analysis tool, which looks at some of the influencing factors. So it looks at a review of the event, it looks at the documentation, and it provides a systematic, structured, and evidence-based analysis to look at, okay, what data do we need to collect? What do we need to look at? How do we identify potential gaps? And what we need to do to improve? And is there anything, other ways that we could have done to drive action plans to improve better and improve in the future? So things like communication, staffing, transportation, other comorbid factors, and some of these things all have an impact on a root cause analysis. It's a very, very important tool in your toolkit. It's not just one, it's one of many things in the toolkit when you're looking at pressure injury development, and it can look at system-wide vulnerabilities as well as localized vulnerabilities. So unfortunately, now when we look at pressure injuries, more and more we're talking litigation. So previously we just heard about litigation in the States, the United States, but now here in Canada, unfortunately, we're hearing more and more about litigation. And documentation is key. Unfortunately, pressure injuries are one of the more common reasons for malpractice litigation against nursing homes and are representing a substantial portion of claims against other sites, including hospitals as well. So making sure that wound care documentation is key. So it's both organization systems, so what kind of documentation system does the organization have, and it's also accountability of all members of staff to make sure that they are documenting both the assessment of what they found, the risk assessments, but also the interventions that they've put in place. The lack of documentation is tantamount to prevention practices that were not done. So making sure that you document what you did do to show that, yes, you did do this, and then what the effective or the impact was. So say, for example, we always teach our staff, if the patient has refused to turn, make sure you document that, but please make sure you follow up and close that loop. Go back to them and try and overcome the barrier. So did they refuse to turn because they were in pain? We needed to provide pain medication. You go back a half an hour later, and yes, the patient's more comfortable, so they're more willing to turn. Or is the mattress uncomfortable? Is their heel offloading boots uncomfortable? Is there other things? Is it because, their family members are coming and they want to be in a specific position to visit with them? So what kinds of things that we can do to overcome, and then how the patient responds to it. So are they willing to engage in the turning and repositioning now? Is there any other gaps that we need to review? So when we look at litigation again, unfortunately, healthcare workers and the institutions both are, of course, naturally very fearful of litigation, both for the financial vulnerability, but also their reputations as practicing organizations. Nobody wants to be that hospital or that nursing home or that long-term care facility where all those pressure injuries occurred. And so it's not just the monetary loss or the financial loss, but it's also the perception. And when we were looking at the literature to look at some of the monetary reports on some of the verdicts and settlements, as you can see here, we've included, and again, these are American statistics. We had difficulty finding many in the Canadian, but these are multi-million dollar settlements. And so just absolutely astounding. And some of the common findings were, again, documentation, disregarding prevention procedures, so not implementing prevention interventions, the perception of neglect and abuse, over-medication, the gap in malnutrition, and looking at equipment care gaps, as well as intervention care gaps that include improper support surfaces, failure to turn and reposition, inadequate treatment, signs and symptoms of infection that have not been picked up, failure to appropriately treat the pressure injury. So making sure that everyone is aware. A lot of lay people don't necessarily appreciate that their skin is an organ, and that they don't understand that when elderly people, so specifically looking at long-term care, as elderly people are starting to decrease in their function or get gravely ill, they can suffer from multi-system organ failure, whether it be heart failure or kidney failure, and there may or may not be medical negligence, but skin failure is one aspect that needs to be considered as far as when the pressure injuries are identified. Was it a result of multi-system organ failure, with the skin being one of the organs, or was it a result of perceived neglect and abuse? And so it looks, so some of these things really highlight the continued importance of research looking at skin failure and avoidable pressure injuries, and making sure that we both educate healthcare providers and the public about the largest organ that we have, called the skin. So how can we close the gap between the planning and the implementation of these prevention strategies? So it's not just the doing of these planned activities. So we need to look at, again, the multifaceted approach that requires both the human, the equipment, and the educational resources, as well as the commitment from the organization, the nursing, the patients, and their families all together. So looking at the documentation that must be balanced with patient care. So you're not necessarily going to sacrifice patient care for documentation, but you should also not sacrifice documentation for patient care. So it takes a village. It takes a multidisciplinary team. It takes a teamwork to care for these patients. There's no one person that's responsible. And so, you know, we encourage the nursing staff, you know, if you're having a really busy shift and you haven't had time to document, get somebody to cover for you. It's very, very important to document the care that you've provided, making sure that you're documenting your regular SCN assessments, your comprehensive assessments, making sure that they're consistent, they're concise, they're chronological, looking at if there's actually pressure injury wounds, making sure you're measuring, making sure that you're have documented any use of specific support strategies, devices such as mattresses or heel offloading devices. Success requires a shift from solely a unit-based pressure injury prevention management approach to a systematic and system-wide hospital-based approach. And so all patient cares. And so, you know, what can one patient unit learn from another? And how does it translate? And how can we transfer that knowledge? So say, for example, in our organization, we're very fortunate that we have heel lift and pressure injury offloading boots available to us, and they're patient specific and they can't be used. And so oftentimes if we notice that the patient is still not as mobile, we'll send them home with the patient. And so making sure that we've educated the patient and the caregivers how to properly use the boots, how to properly assess, and that the boots don't take the replacement of assessment of the heels, for example, but they are one tip and tool on helping to offload the pressure from that site. So when we're looking at pressure injuries, we need to make sure we react. So make sure you react. Remove the source of the pressure, and I wish we all had beds in this picture. I just giggle when I see this picture every time I see it. So remove the source of the pressure, ensure you protect the skin, make sure you assess and evaluate all your interventions, make sure you're communicating with your team, and talk to your patient above all. So recently launched, exciting news for Canada, and hopefully you're all aware that the Canadian Pressure Injury Advisory Panel has been developed and implemented. And the mandate for the CPI-AP, as it's now called, is to act as a unified voice for Canada. It supports the adaptation of the International Pressure Injury Guidelines for Canada. It's meant to raise public awareness about pressure injury prevention and management, advocate for practice and policy changes to improve patient care, and to enhance the scientific evidence that will support stronger evidence-based practice. And as Debra already said earlier, there's lots of opportunities for research and evidence-based practice that needs to be developed here in Canada, and we want to absolutely promote Canadian content. Pressure Injury Prevention Day, as we know, this is the day. And I just want to highlight some of the education series that have happened and are upcoming through CPI-AP. And so you can see on the slide on Friday, November 19th, there's a presentation on pressure injuries and PPE, which is of course very, very timely for us right now. So this is a wonderful example of how Canada is getting on board and becoming an international influencer and having a voice at the table on international pressure injury prevention. So we just want to say thank you very much for listening to our presentation, and we really appreciate being invited to speak at this symposium. There's many more to come, a lot more work to be done, and we look forward to working as a team with you. Thank you very much for having us.
Thank you. Thank you so much, Debra and Leslie, for such an engaging and relevant presentation. I'm certain many joining us today can relate to the complexities of pressure injury treatment and prevention, and also value all of the data and evidence-based best practices presented here. We invite attendees to come to the Mölnlycke booth if you have any further questions for Debra or Leslie, since we've run out of time. So thank you so much, everybody, for attending today.